where's our future going? Are we trying to measure glucose metabolic status in real time? Might we someday want to measure thyroid metabolic status in real time? What would we want to measure? If we could create a wearable device that would measure 1 or 2 thyroid hormones, would we choose TSH? I think we would choose reverse T3 and free T3, which is going to give us a much more accurate real-time measurement of what's happening with the thyroid. So if we think about it from that context. Okay, so now we're left with a clinical situation of my patient's thyroid TSH is normal, and yet I know that their function might not be normal or optimal. I know I can make them feel better if I can motivate them to make some changes in their life and in their environment. How do we explain this to patients? Let's return to my Hamlet and my Othello. Think about shoes. We know that the normal men's shoe size is 7 to 13, and I happen to know Hamlet wears a size 9. I happen to know that Othello wears a size 11. Hamlet, your shoe size is normal. Men's normal is 7 to 13. You're normal. Could you function in a size 11? Could Othello function in a size 9 when he needs 11? Most of our patients are women. So we can say the normal women's shoe size is between 5 and 11. If you wear size 7, how well would you function in a size 9 shoe? And then you can explain to your patient, the normal thyroid function is said to be 0.3 to 4, but you need to be at about 1.5. Your test says 3.5. It's in the normal range, but it might not really be good enough for you in the way that a size 9 might not feel really good to your size 7 feet. Okay? So just read this slide to reinforce what we've talked about. Think about the limits of reference ranges and think about the temporal trend. Look at your temporal trend of your TSHs. If it's moving from low normal to the high end of the range, you might want to consider what's their thyroid function doing. And of course, we have a toolkit item to help you explain this to your patients, to your skeptical colleagues, and to anybody who needs to understand this. And you can obviously refer to the data from this presentation. Okay. So TSH is recommended as the sole criterion for monitoring T4 replacement therapy, and really for just about any thyroid condition. We're going to present some evidence which will question that as well. And that will lead us to think about, do we need to be testing free T3 and free T4? In the context of PTSD, if TSH is the sole criterion, it would have to detect changes in production, transport, conversion, sensitivity of thyroid hormone, which would lead us to ask these questions. Can it reflect variations in sensitivity, in conversion, in transport into the mitochondria, in replacement off a receptor? We think the answers are no, 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 and no. So we may need to consider something in addition to TSH, and the European Thyroid Association agrees with this. In terms of T4 replacement, they have concluded from the evidence, TSH alone may not be a good marker for the adequacy of thyroid hormone replacement. So, again, close your laptops and let's just look up at the screen. You can stand up and stretch here. This is a reading exercise. You need to digest this. This is the current recent evidence that's emerging that informs us that some things we used to think about the relationship between T4 and TSH may not be so, according to some newer evidence. So read these to yourself, and I'll make some comments after each of these slides. We used to think T4 goes down, TSH goes up. It's not that simple. That's what happens in many environmental conditions, but not all of them. It's more complex than that. That's what the emerging literature is showing. Read this one. TSH might need to be scaled back to a supportive role, not the only criterion. You need to consider measurement of free hormones, T3 and T4. More evidence. This one's from Lancet, 2015. This is referring to patients taking T4. And this refers to Helen, does it not? She's taking T4. Maybe her T3 is not going up. She might not be converting. A lot of patients do not convert well. So we have to think about that. We have to think about testing ratios. A T4 to T3 ratio might be very clinically informative. 2017 research. Reinforces when T4 goes down, TSH does not necessarily go up. What they're calling this is tracking. Sometimes when T4 goes down, TSH tracks with it and goes down also. Explaining the normal TSH in people with low thyroid function. Demands a paradigm shift of the diagnostic use of TSH. Next set of research. To this point, we've had dogmatic confidence in the deiodinase enzymes to convert T4 to T3. And it's not the same in all individuals based on their genetics, and it's not the same in all environmental conditions as we've seen. The environment will influence conversion as well. So there's many reasons why the conversion of T4 to T3 may not occur. Now, you can get seated again and settle in for the final stretch here. Let's balance this with the Choosing Wisely recommendations, which are excellent recommendations from our specialty organizations to help us choose laboratory tests wisely and not needlessly spend healthcare dollars. How do we walk this balance of knowing that TSH alone might not be adequate and yet being responsible physician citizens with healthcare expenditures? Well, this society says the initial evaluation, do not use extra tests, only test TSH. But then depending on findings, you might need to do other testing. And the Endocrine Society says in hypothyroid patients, do not order free T3 when assessing replacement. So this is good for healthcare expenditure, but we've got compelling evidence now that this might need to change. Okay, so we've got competing evidence that we have to balance now, and it puts us in a quandary. Let's look at the deiodinase enzymes now. What do? They remove an iodine from the T4 to convert it to active T3. And we've looked at this question now. T4 and TSH levels being normal do not ensure normal T3. Here's one of many studies we could have chosen. They've taken patients who've had their thyroid glands surgically removed, replaced them with T4 to get their TSH in the normal range, as you see here, to get it to 1.4. They had a control group. When they gave them T4 to replace it, what they found was when they measured T3, 15% of patients, they could not get the T3 to move into the normal range. 30% of the patients taking T4, they could not get the ratio of T3 to T4 to normalize. This strongly implicates problems with conversion. If we look at one single SNP, the RS225014, 15% of the population has this SNP, which will impair conversion. Why would this survive in the population? Why would you want somebody who easily lowers their thyroid hormone metabolism? Famine? Adverse environmental conditions? These individuals might have survived historical adverse environmental conditions better than those without it. So these kinds of polymorphisms persist. You will have individuals in your practice for whom you give T4 and nothing's going to happen. It's not going to convert very well. 1 out of 6 just based on this single SNP alone. So our conclusions are the TSH may be normal, but T3 may not be normal. T4 may be normal, but T3 may not be normal. Conversion. Both TSH and T4 may be normal, but the ratio of T3 to T4 may not. And that T4 and that TSH may not reflect the accurate state of thyroid metabolism in your patient. And the European Thyroid Association, again, concurs with this conclusion. I'll let you read this. They are advocating ratios, this T4 to T3 ratio. We'll talk about this in a moment. We're also going to talk about a different ratio that with our clinical experience over the past few decades in functional medicine clinical care, we have found to be useful. And we will be transparent. This is not validated. There's not a lot of strong published literature for this. There's a strong evidentiary basis in our clinical experience. reverse T3, measuring that hormone, and measuring reverse T3 ratios. And for this, I would ask you to think back to what you just learned about cortisol steal, the blockage of an enzyme so that you favor another pathway. Remember, blocking 1720 lyase, so you disfavor production of sex steroid hormones and you favor the production of cortisol. You need this in many adverse environmental conditions. Well, in many of those adverse environmental conditions, there's a similar condition that I like to call thyroid steal. Same principle. It's going to block an enzyme to help your thyroid metabolism become optimal under those environmental conditions. So here's the basic branching point. You start with T4, and different enzymes will either convert it to free T3 or reverse T3. If you've got D1 and D2 activated because of the environmental condition in which the patient finds themselves, you'll produce free T3 and increase your thyroid metabolism. You'll inactivate reverse T3 and change it to inactive T2. Different environmental conditions, adverse, D3 will be activated, block conversion to free T3, promote conversion to reverse T3. Beneficial for that environmental condition, but could be problematic for how your patient's going to feel. What can block D1 and D2? So I call that thyroid steal. Sometimes it's iatrogenic, but how does this list of D1 and D2 blockers match our 8 domains? Can you help D1 and D2 convert on Monday morning by using this list? Yes, you can. So when do we consider this ratio? Again, we emphasize, consider it when you know that your patient is in a time of environmental stress, whereby it might be beneficial for them to produce reverse T3, to generate that thyroid steal response. We don't have the research evidence yet, but we do have the clinical experience for this. So again, think about that. And what we found from our clinical experience are these ratios. If you're measuring a free T3 to free T4 ratio, you want the T3 to be high, the numerator. So you want the ratio above 0.33. If it's below that, that means you got a lot of T4 still hanging around that's not getting converted. If you're going to measure a total T3 to a reverse T3 ratio, you want to be sure that the reverse T3 is low denominator, higher numerator, higher number. So you want that ratio above 6. Mathematics. Okay, let's take a deep breath and close your laptop so you're not looking at the answers. Let's assess some ratios with Helen. Here's Helen's data. You're going to notice that I put all of her lab analyte results in the normal range, but at one end or the other of the normal range. So her total T3 and her reverse T3, are they normal in the population-based range? They are, but they're in the low end of the range for total T3, the high end of the range for reverse T3. So might she be experiencing a mildly or moderately adverse environment based on that alone? Do you suspect? Question, is her total to reverse ratio normal? We want to see it above 6. If we do the math, total 100 divided by reverse 25 equals 4. Not high enough. Okay? Which means the denominator is a little too high. Reverse T3 is too high. She's got more reverse T3 than we would like to see. Next question. Is her free T3 to free T4 ratio normal? We see that her absolute results are normal. The free T4 is in the low end of the range. The free T3 is in the low end of the range, barely. If we do the math and divide free T3, which is 3, by free T4, which is 12, we get 0.25, lower than that reference range that we suggest, which means the numerator, the free T3 is too low. She's not converting T4 to T3 very well here. All right, we'll go into our last chunk of content now. Let's summarize the lab testing we've talked about. Let's talk then about what you're going to do on Monday morning with what you've learned in the course thus far. Reference slide for you. Take a look at this. On the right side, the standard reference ranges for most labs. Check your own lab because these can vary by geography and company. On the, did I say left? On the right side. On the left side, are the optimal ranges that we suggest from our clinical experience. Also, the reverse T3 ratio there and the T3 to T4 ratios are there. Antibody levels are there as well. We want to choose wisely. In selected patients, we might need to test for nutrients. But if we use a food-first approach, if we do a good history, a good gathering, use our timeline on our matrix, we should understand who's going to be nutrient depleted. We should be able to use food first. And only in selected patients test for these laboratories of nutrient repletion. Selected patients, we may need to assess celiac panel and food sensitivities and toxic minerals as well. Again, if we cannot get results with the basic low-cost, low-harm interventions, we can turn to those. Let's move now to our final performance objective. How are you going to take what you've learned in this course so far? The antecedents, triggers, mediators, modifiable lifestyle factors, and on Monday morning, start to change your patient's thyroid hormone production and conversion and sensitivity. So I'll ask you again to close your laptops, not look at the answers, look up at the slides. Let's treat Helen here. What did you learn earlier in the course at the very beginning? What are your patients going to benefit from in terms of the mnemonics that you used for gut intervention? How are you going to treat Helen? You know for 40 years she's had gut problems. You're going to evaluate her with dig in, right? And you're going to treat her with the 5 R's. She's had gut problems for 40 years. You can safely do that. No labs, no supplements. Now, a little more complex. What are you going to do about her lifestyle factors? And make them personalized, not just population-based interventions. How can we personalize her lifestyle interventions? I would argue that you need to ask that important question, which is evidence-based medicine as well. Helen, what do you want your health for? What do you value? She values time with her grandchildren. She wants to have energy to play with her grandchildren. She values time with her friends. She wants to change her mood so she feels like going out with her friends. How can you use her friends and her grandchildren to improve her lifestyle and make some interventions there to change her behaviors? Use them. Use the patient's values and preferences to help them change their behaviors. Nutrition. Can you help her with her nutrition profile right now? You know this is pro-inflammatory. Have you learned in the course how to make changes here? Yes, you have. What will you do for Helen specifically? And then toxins and inflammation. We haven't tested her for toxins. We haven't tested her for inflammation. Do we suspect that she might be toxic? Do we suspect? What can we recommend for all patients to help them avoid toxins, lower their toxic burden or exposure? What can we do for all patients to help them lower their inflammation? We address our 8 environmental domains, and we'll address all of these things. So let's turn to the matrix. Now, this is what I would have done. It might be different from what you would have done. If I look at nutrition, and I'm trying to do this for Helen, who doesn't want to spend a lot of money, I'm going to look at beverages. That soda, Helen, can you drink some water instead of soda? Can you change it all to water instead of soda, maybe? Brazil nuts. Those thyroid-containing foods she has to eat, she can eat those thyroid-containing foods. She's going to get those 6 handouts. Colorful foods, inflammation. We know that if she eats more colorful foods, she's going to convert her T4 to T3 better, right? And that T4 that she was taking, if we ever restarted, it might actually help her. With movement, I'm going to say, Helen, walking in the woods has good evidence that it will lower your stress, and you'll actually feel better because of that. And if you do it with your grandkids, take your grandkids for a walk in the woods. Kids love yoga. We know that yoga is good for your thyroid function. Get your grandkids to do some yoga with you. Or maybe she does yoga after dinner, and after that, before bed, she takes an Epsom salt bath after the yoga. How does that help your sleep? What does that do for your thyroid function, right? Walking in the woods, or maybe walking in sunshine to get more vitamin D to lower her inflammation. Those would all be good interventions. No labs, no supplements, you've improved her thyroid function. Relationships. Find something the patient used to like to do. Helen used to sing in the church choir. How about rejoining that church choir? That's a good way to get connected with those people again, Helen. How good is singing for your physiology? What does singing do to your cortisol levels? You sing, you improve your conversion of T4 to T3. She's doing it with friends. She's connecting. No labs, no supplements, no cost. Stress. Everything we've mentioned lowers her stress. You can do this on Monday morning. We haven't spent a dime. She hasn't taken a pill. We've improved her thyroid production, conversion, and sensitivity. And to go beyond that, if you can motivate her to go gluten-free and dairy-free, even better. If you can motivate her to go on an elimination diet, and if she's autoimmune, a renew diet, even better. Inflammation, we've talked about the sunshine. How about fermented foods, if she can tolerate those, or find one that she likes? How about a better omega-3 profile in her diet? Lower inflammation, lower cortisol, improved conversion. Toxins. You can recommend organic foods, especially the Dirty Dozen, if she can afford it, right? Selectively removing the foods that are the most toxic in her diet after you assess her diet, nutrition, lifestyle journal. Send her to the Environmental Working Group website where they rate every personal care product from 0 to 10 in level of toxicity. Get her to swap out the high numbers for the lower number personal care products. Lowers her exposure to toxins, spends no more money. But Dr. Luby, we just learned we don't treat the thyroid first, we treat the adrenals first. Based on Helen's profile, do you think she has adrenal problems too? Oh yes. Did we address the adrenals by the way that we addressed the thyroid? Oh yes, we did. Because these lifestyle interventions that you've recommended for her will also improve her adrenal. Food first. What are you going to do on Monday with your patients? You're going to understand that you want them to be eating low antigenic foods, prebiotic foods that you've learned about now, probiotic foods, high phytonutrient, high color content, lower that inflammation, lower that cortisol, improve that conversion, omega-3, and a good fatty acid profile. IFM tools and food plans to help you. The short-term interventions, elimination diet, excellent for somebody with low thyroid function. That's going to improve inflammation immediately. Thyroid conversion improves in those 30 days on the elimination diet. If she's got an autoimmune condition, renew, maybe even better. Longer term, for a maintenance food plan, think about inflammation versus toxins. If you think your patient's problem is more inflammatory based, cardiometabolic diet or food plan is probably best. If you think they have a predominance of toxins affecting their thyroid production, conversion, or sensitivity, maybe you want to go with a detox food plan, and you'll learn about that later in your training. Only in those patients you need to, think about supplementing the nutrients. Those are the nutrients you need to focus on. You've got your toolkit handouts to get them those foods. You've got your doses if you need to supplement, but most times you can do this with food only. If you need to go to those nutraceuticals or botanicals or something else, the evidence we have so far favors black cumin. You can see that it raises TSH and free T3 levels with a mechanism slide depicted here and the reference for you to study on your own. And another one we can call out is ashwagandha, improving free T3 levels. But we want to be cautious about this. Does the patient really need supplementation of this sort if we can do it without pills, without cost, with other interventions? We can improve their thyroid function in other ways. And we want to stay away from over-supplementation. And functional medicine at times is justifiably accused of over-supplementing, or certain clinicians might be. Because we can do a lot of this without supplementation. I had to do it in my practice. Again, Latino community health centers. Often they don't even have insurance, but they certainly don't have funds and resources to buy these supplements or pay for these lab tests. So if we over-rely on supplementation, we might end up in supplementation. And we can do it in a different way, not with supplementation, but with supplementation. Because what we're talking about here is getting to know your patient and using your mind to personalize their treatment approach. That's supplementation. That's what functional medicine is all about. And the supplementation of functional medicine is represented here. When you encounter a deficiency state, these are your principles. We've been over this before, but it's nutrition first, food first on the top. Then it's lifestyle and behavioral changes. And then it's addressing those antecedents, triggers, and mediators. And then only turning to supplements if you need to, and making sure every intervention you do has an excellent risk to benefit profile. Because this is what your patients are encountering. This is what their thyroids are encountering. Form follows function. Function follows environment. It's the environment that determines the physiological function of the thyroid. You're going to be environmental doctors here, addressing the patient's thyroid gland to help it do what it naturally does, to respond to changes in the environment. You're going to intentionally help your patient change their environment to change their thyroid response. So we'll give T4 if we need to. We'll try to assess whether it's actually converting to T3, but we'll understand our greater leverage on Monday is to address their environment, to improve the production of T4, improve the conversion to T3, and improve the sensitivity at all the receptor levels. And you'll do it the way we did with Helen. Address those 8 domains and help your patient return to flourishing thyroid hormone axis health. Thank you.